I'm Jamie. I am from TCC. I am the nursing tutor, and I've been there for about a little over 2 years. I'm also one of the clinical instructors. I also, because I don't have enough on my plate with that, I also work full time at St. Michael's out here in Silverdale on our critical care step down unit. I've been there 6 years, so I have a little bit under my belt of education. Um, and I'm in school for my master's. All right. Um, so, kind of the breakdown for today is we've got a scenario that we're going to play for you guys from our sim center that we have the mannequins that are lifelike. Um, and we're going to just go through the scenario, kind of show you guys what we do in the real world, sort of, and break it down for you and answer questions, show you guys some of the things, and we'll kind of go from there. And I also have Eileen with me and Joe. If you guys want to introduce yourselves real quick.
Yeah, of course. Hi, everyone. My name is Joe. I am currently a registered nurse at St. Joseph's Medical Center in Tacoma. I work with open heart patients in the cardiac critical care. I'm also at Good Samaritan Hospital in their medical surgical intensive care unit.
My name is Eileen, and I recently just graduated from TCC's nursing program about almost a month ago, and I am currently working as an LPN at a home care facility.
Okay, so I have a video that of the scenario that we're gonna kind of just play for you guys. And we'll see how it goes. Hopefully you guys can hear. If you can't, okay, guys. So this is our what we call the sim center. This is one of the beds there. These are three of our lovely students. We have the mannequin, and the mannequins can scream, which is really fun to do. We have one that is able to simulate labor and birth. You can feel pulses. They blink, they drool, they vomit, they have heart sounds, lung sounds, bowel tones. They are as close to the human body that we can get without actually it being a human body. We're able to give fluids into what we call the vein, and that kind of, so we can hang fluids. We also have arms designated for starting IVs. What else? So these are what our students practice their hands-on skills before they get into the hospital. So in this scenario, we have this student here. She is playing the role of the EMT, and then she's also going to come back, I believe, at one point in time and play a different role. We have this student here who's playing the role of the nurse getting report from the EMT, and then this is an assistant, is another nurse being helping out. This is a patient who came into the ER with chest pain. And so this is one of those scenarios that is very common for our students to go through.
Okay, this is Maria Polo, 67-year-old female. She called for complaints of chest pain that have been intermittent since this morning and have gotten increasingly worse over the last hour. There was no ST elevation on the monitor. She was sinus tachy, oxygen at 90% on room air, blood pressure 160 over 96, respiratory rate was 21, and heart rate was at 110. We did give her one nitro 5-milligram tablet about 10 minutes ago, and that was all. She's still complaining of chest pain. Do you have any questions?
Oh, the nitroglycerin was given how long ago?
10 minutes ago.
10 minutes ago? All right. Hi, Miss Maria. My name is Juhi. I'm your nurse today.
Can you guys hear
Maria,
it?
My name is Jan, and I'm here working with Juhi. I'm going to go ahead and get you started. Oxygen. I heard that. Turn it on. 2 liters. I heard that you came in for chest pain today. Is that correct?
Yeah.
And how would you rate your, when did that start? About 2 hours ago. And And how would you rate your chest pain at 0 having no pain and 10 being the most pain?
About 9.
About a 9, okay. And do you take any, do you have any histories of chest pain?
No, I have a history of high blood pressure and I'm a diabetic.
Okay, you have hypertension and diabetes?
Yes.
And do you take any medications at home right now?
Metformin and lisinopril.
Metformin and lisinopril. And do you take any over-the-counter medication?
No.
Okay. All right. So, Miss Maria, I'm gonna talk to Dr. Joe, your doctor, and come back with about your condition, and he'll come in to take a look at you. Okay.
Okay.
All right.
Okay, Juhi, her lung sounds are clear, heart sounds are normal, but her pulse is rapid and her brachial pulse is bounding.
Okay. Rapid pulse with bombing. I'm gonna get her rest of her vital signs, and I'll call the doctor.
Maria, while Juhi goes and talks to the doctor on call here, I'm gonna stay in the room with you, okay?
Okay.
Oh, hi, Dr. Joe. We have a patient, Maria Joe. She's 67-year-old female who came in for chest pain. That started 2 hours ago. She rated her pain 9 out of 10. She has no history of chest pain. She has hypertensive and she's diabetic. Her blood pressure right now is 160/86, heart rate of 121, SpO2 at 98 with 2 liters per min of nasal cannula, temperature 37.3 degrees, respiratory rate 18, and she had nitroglycerin 5 milligrams sublingual 10 minutes ago. Her lung sounds are clear, heart sounds normal. She has rapid bounding pulse.
All right. Hello, Miss Maria. My name is Joe. I'm going to be your doctor here in the emergency room. So, Judy, I want to go ahead and start some normal saline at 100 mils per hour. We're going to start some heparin at 800 units per hour. We're also going to start some nitro sublingual 5 milligrams 3 times as the max dose as needed for chest pain. We're going to also have morphine on standby for chest pain as well, 2 milligrams IV pushes every 15 minutes for pain over 7. And let's go ahead and do a 12 lead EKG. And you already got some oxygen started. Make sure the SpO2 is over 92%. Let's get also some labs started. Let's do a BMP, a BNP, CBC, a troponin, and CKMB.
Okay, I'm gonna repeat the orders. I have normal saline running at 100 mils per hour, heparin 800 units per hour, nitroglycerin sublingual 5 milligrams times 3 max, morphine 2 milligrams IVP every 15 minutes, 12 lead EKG, keep SpO2 above 92, a lab draw of BNP, BMP, CBC, troponin, and CKMB. Is that correct?
That is correct, and I'll put those orders in right now.
All right, thank you.
Update me if there's any changes in condition.
Okay, all right. Yana, is it okay for you to grab some medications for this patient? We have, as you heard from the Dr. Joe, we have normal saline, 100 mils per hour, heparin running at 800 units per hour, nitroglycerin 5 milligrams times 3, morphine 2 milligrams, IVP for pain. And I'm gonna ask Casey if she can start on the 12 lead, and then can you also do the lap draw for Rainbow, please?
Yes, ma'am,
All right, thank
Okay.
you.
I'll get Maria started on the normal saline, 100 ml an hour, morphine 2 milligrams IV push, nitro 5 milligrams, and heparin 800 ml an hour.
Okay. Ma'am, I'm gonna do an EKG. I've got 10 stickers. I'm gonna put on your shoulders, chest, and hips. Miss Maria, we're gonna grab some medications to start with. We're giving you some pain medication and some nitroglycerin to help with your chest pain, okay? Miss Maria?
Okay. So this is just kind of showing you what you hear a lot of like echoing and a lot of repeating. Does anybody know why? Why we repeat everything that we hear? Okay.
I think if you have a microphone, it's okay that if you use your microphone.
Because
and
I
if you-
can't see the chat when I'm sharing the screen.
Mhm.
A couple people are saying, so Nucha said, oh, it's basically just, yeah, like to make sure everyone is on the same page and everyone is able to hear and understand like what's going on.
Yeah, we want to make sure that when the doctor says, okay, 800 units of heparin is a blood thinner. So, and that's a medication. We want to make sure that we're giving we heard it correctly. It's one of the reasons that's so great. One of the great things about the electronic health record, or whatever we're calling it, our system Epic, where the doctors have horrible handwriting because they're writing so much and so fast that we echo it, we repeat it so that we hear it correctly, that we can follow through properly and safely. So we call it echoing, and repeating what we hear so that we can make sure it's correct. You hear that we're giving morphine, oxygen, nitro, and although we didn't do the aspirin, we call that Mona, and that is for anybody coming in with chest pain. We give morphine for pain, but it also helps relax the heart and help with perfusion, keep everything circulating. We give oxygen because that helps oxygen continue to circulate in the body. Nitro is for the chest pain to help relieve the chest pain, and then aspirin is a low dose blood thinner, so we can keep the patient, if they are having a heart attack, from maybe having a stroke or blockage. We want that blood to be thin because it'll help circulate in the body. And right now that we're doing an EKG, which is all these little lines back here on the monitor, it's showing the heart rhythm. So we have measurements that we're taught that if that are 4 different heart rhythms that you'll learn one day in school. So there's a lot behind the scenes that is going on.
Yana, I have last for your patient. Maria Polo here, her BMP came back within normal limits. Her BNP was 1,038. Her CBC was within normal limits. Her troponin was 18.1, and her CKMB was 54. 54. Yes.
So I have BNP within normal range. BNP of 1,038, CBC within normal limits, troponin at 18.1, CKMB at 54.
Yes. Okay, thank you.
Miss Maria, are you still with us? Maria, are you still with us?
Yeah, I'm just a little overwhelmed watching our work. There's a lot happening.
So after we give you some nitroglycerin, it's gonna make you a little bit anxious, and you might feel palpitations, but it's normal, okay?
Okay.
All right.
And I'm just hooking up your fluids right here, Maria. This is just going to keep you hydrated, okay?
Okay.
Got your EKG printed out? Thank you so much. You're welcome. Did you get her nitroglycerin yet?
Okay. Okay. Okay, Miss Maria, I'm just gonna go call your doctor to update your condition. How's your chest pain right now?
It's still there.
It's still there. How would you rate your pain at?
About a 7.
7. Okay. All right. I'll be right back. Okay. Yana's gonna stay with you and finish hanging up the rest of the medications. Okay.
Okay.
All right.
Her vital signs at 1640 was at 159/86, heart rate of 119, SpO2 at 99 at via nasal cannula at 2 liters per minute, respiratory rate of 18, temperature 37.3. She rated pain 7 out of 10 with first set of nitroglycerin.
And here's her EKG. Her blood results came back. Her BMP is within defined limits. The NP was 1,038. CBC within normal limits. Troponin at 18.1. CKMB at 54. Do you have any additional orders for Maria?
Yes, so let's go ahead and give her a push of Lasix 40 milligrams just once. And I'm going to contact cardiology and we're going to try to get her to cath lab as soon as possible, all right?
All right, so I have orders for Lasix 40 milligrams IV push and prep for the patient to go into the cath lab.
Yes, and we're going to go ahead and call a quick STEMI. All right.
Okay, we're going to call code STEMI. Okay, Maria, Dr. Joe just ordered for you to go into.
Okay, so do you want to talk about a code STEMI here for a minute with me, Joe and Eileen?
Of course. So a code STEMI, we call that in the hospital with a patient that's coming in or is already there. It stands for ST elevation myocardial infarction. I'm going to go ahead and break down those words. Those are some big words going on into one little thing. So a myocardial infarction is just a real fancy term for a heart attack in the hospital. And when someone has a heart attack, some parts of the heart, how it affects the electrical conduction system in your heart. So your heart starts beating because there are little signals in your heart that is affected by how your brain starts signaling into your heart. And so an electrical conduction system basically is telling it, each part of your heart, how to beat. And so when you have a heart attack, there are certain factors that can affect that electrical conduction system. And we have unfortunately, I don't have like a little printout to show you, but there's a part of how your heart rhythm goes, and it can elevate certain parts of your heart, the electrical conduction system. And so there's a part called the ST segment, and that will be elevated. And that's how sometimes our providers and doctors see how a person has a heart attack. I'm sorry, that's a lot of information all at once, but but if you have any more questions about that, please put that in the chat and we'll try to answer as much as we can.
So this is where in the video, we're now calling a code STEMI, and that can be also anywhere in the hospital. It could be in the ER, it could be on one of the units, wherever we call it. It's just what we call in the hospital, and that also starts a whole cascade of just protocols and orders that flow into place that happens. So the cath lab will then take whatever patient they have on the table, they get them out, and then they get that room ready for us to take the patient in. And then there's, like I said, there's a whole other cascade of things that happen. And so when we're calling that, cardiology then comes on board. They will then come and see the patient, and while we prep for cath lab. And that's kind of the process that you're going to somewhat start to see.
For you to go in, and the doctors will be able to observe how well your heart works, and to see if there's any occlusion in your heart vessels. Do you have any questions?
I'm just so overwhelmed.
I understand. I'm so sorry. I know. I'm so sorry. Do you want me to call Dr. Joe to explain further procedure? Do you have any questions? Concerns?
Not at the moment.
Okay. And I understand that you feel so overwhelmed, and I'm so sorry about that. It's just we're here to make you feel better.
Thank you.
All right. So I'm going to get some Lasix for this patient. Would you be okay with staying with the patient? Yep. Okay, thank you.
Okay, Maria, I'm starting you on a heparin drip. What heparin is, it's a blood thinner. So we're just going to prevent some blood clots, okay? Okay. And I know that Dr. Joe has ordered you to go to the cath lab. I'm going to have to grab you an informed consent paper for you to sign. So I'll be back in just a second.
Your question? Morphine?
Yeah.
Okay, thank you.
Okay, Maria, so this is the informed consent for cath lab. Did Juhi or Dr. Joe explain what the cath lab is to you?
A little bit, not much though.
Okay, so in cath lab, what you could expect is that the doctor's going to insert an IV, probably in your arm, it's right here or at your wrist. And the goal of this is to open up your arteries of your heart, so this MI doesn't kill any more tissue, your heart is reoxygenated, and you get all better, okay?
Okay.
Okay, so you just sign right here. And I'm gonna stay right here with you, Maria, okay?
Thank you.
Hi, Miss Maria. I'm back with your medication. Is the patient stable?
Yes, she's stable.
Okay. Can you test and see?
Yes. And if it's okay with you, Juki, I'm gonna go.
Are you doing okay? What's wrong? Miss Maria? Miss Maria? Miss Maria, are you there? Maria? Okay. Code blue? To room 3, please. Miss Maria? Gonna start CPR. 3. Square behind you, please. 9, 10, thank you. 7, 8, 7, 8.
What's going on?
Miss Maria just started yelling and then stopped breathing. CPR. 1, 2, 3.
Pulseless and stop breathing.
9, 10.
All right, let's go ahead and put the defib pads on. Let's get a round of epi ready.
3. Is it on? Them. Yeah, oxygen up for me too. How much? 10 liters and then you put it on there all the way. 8, 9, 10, 11, 2, 3, 4, 5, 6, 7, 8, 30. I have epi. Second IV, 18 gauge left.
We have the defib pads on.
CPR, get 2, 3.
All right, is it connected?
6, 7, can we connect it? 10, 11, 12, 13, 14, 15, 16, 17, 18, 20, 21, 22, 24.
We'll hold off on the epi until we see the defib is working.
Resume. 1, 2, 3. Clear.
Continue. Clear. Is everyone clear off the bed?
Clear. Let me know if you need to switch.
Yeah, go around on the other side and switch with her.
Switching in 5, 6, 7, 8, 9, 30. Switch.
Push this epi over here. We're going to go ahead and give one round of epi right now at 15:55. One round of epi being given.
Epi push. 3.
All right.
Resume CPR.
All right. Check pulses. Are pulses okay?
No, there's no pulse.
All right. So that is what CPR looks like on a patient. So yeah, that is what a code looks like. I went to nursing school. I did my ADN first, so I was in school for 2 years. And then I did my BSN, which was an additional 18 months. But I took the long route to get to nursing school. If you decide, just stay in one place, do the program, and then move, travel, or whatever. Look and see. My credits didn't transfer from Maryland to Texas, so that delayed me a few years. Questions on the scenario. One of the things that you see a lot in TV that was on the video that isn't true to real life is we do not shock asystole because the defib machine wasn't actually reading a real heart rhythm. It's just programmed to say shock advisable. In real life, if you're have a flat line, we do not shock that. We do continuous compressions. Also in the hospital, that's different from the CPR that we're taught if you find somebody down in the real world, is CPR is continuous. There's no 30 and 2. RT is doing, respiratory therapy is doing their thing during the code. You do not stop compressions unless you're feeling for a pulse or you get a rhythm. That is a survivable rhythm. Yes. I was a CNA for about 8 years in Texas and then got into the nursing program. I know up here it actually gives you guys points getting into a nursing program, I believe.
Yeah, when I was applying for TCC here, I had my CNA first, and that gave me more points to get in to TCC.
For the schooling recommendations, it's kind of just what you're looking for. You can go the community college route, which I'm pretty sure all three of us actually went through. It goes, that's to become an RN. It doesn't matter whether you're going for your bachelor's or if you go to a community college. Both of them will get you the same registered nurse license.
Sorry, keep going.
No.
Or I would also say one of the really big important things about choosing a nursing school is make sure they're accredited, because I remember for my LPN, they were still getting their accreditation, and that almost messed a lot of us up, but thank God they did. So we're all in the clear for that. So make sure they are accredited.
I also want to say, also take into your financial situation. Community colleges are cheaper, but you're still going to walk away with an ADN. You and a BSN are going to be making the same thing. You're just going to be in a lot less debt than a BSN. And there's a lot of really great schools to do the RN to BSN, but you and a BSN are going to be making the same exact thing at the end of the day.
But for your bachelor's, it is also another way to, because once you get your associate's degree at a community college, there is a push for hospitals to encourage nurses to get their bachelor's degree. And if going further on with your schooling to become a nurse practitioner or going into leadership, they will require you to get your master's or your doctorate degree at that point. It is somewhat easier just to get your bachelor's out of the way first so that you can just continue on with your education if you want to go into those roles.
How do we balance school and personal life? A lot of time management.
You'll learn early on, and even during your prerequisites when you take it, on how to manage your time, because nursing from the get-go, like from when you even start thinking about nursing, it's hard, and you'll have to learn how to prioritize like what what times don't change, like like managing a study time frame that won't change, and then like family time that won't change. Like you would need to be able to figure that out.
And I think that flows into just living the career, is balancing. There is a balance. Missing holidays, we work, but at the end of the day, we're working from 5 a.m. to when we finally get home, back at home, to 8 a.m. depending on what we do. But we are living the life from when we get up to when we finally come home. And those 12, 13, 14-hour days do take a toll. But it's an amazing career. I absolutely love it. I cannot see myself doing anything else. It's a life that is very rewarding, but it's also very hard. But
That
it's
goes
very
for
rewarding.
And that goes for any of the medical fields, even if
Yeah.
you're not interested for nursing. I saw a question about maybe someone wanted to become a surgeon. Surgeons can be in the operating room for very
For
long.
20 hours, depending.
Long time.
Long time.
And so
Long time.
I respect surgeons because I can't have
Yes.
like an attention span for that long.
But-
Yeah.
But in general, I think school and personal life balance to whatever field that you're going into, you just got to learn when you got to study and when you got to,
Mhm.
go with family and your loved ones.
Yep.
Like my typical week during nursing school would be like I would go through nursing school during the week, I would work during the weekends, and then usually on a Sunday I would spend some time with my friends or with my boyfriend or like with my family while also studying, but I would limit it just a little bit more.
Yeah. How much debt does the average nurse have? Um, for a BSN, like my bridge program was about 15,000. I graduated nursing school with my ADN with no debt.
Same here.
Because I worked, and I made a deal with my mom. She would help me pay for nursing school. I would make sure not to put her in a nursing home when she got old. So if you have parents like my mother, make a deal. You don't go to the nursing home unless you get Alzheimer's. That's the only way I'm putting her in a home.
I went to sorry.
No, so yeah, so my debt is my BSN and now my MSN, and that's it.
I went through Running Start for my prerequisites and got that out of the way. So my high school basically covered up my prerequisites and all the things that I needed to graduate high school. But my parents were able to pay off my nursing school for the past 2 years. So I'm pretty good there. And I think I would still be okay for my bachelor's like when I go back.
Yeah.
And do not underestimate the power of scholarships,
Mhm.
Yes.
especially as nursing. We have a lot of scholarships in circulation that are not being in use. Look for them.